Welcome, everybody, to the Mental Health Committee for Allied. Uh, we do so many different lectures during the year, anxiety, depression, mental health issues, and we thought, what good is our advice if we can't get our patients to follow it or can't get them to see our way of thinking? So more and more physicians are learning about motivational interviewing. You'll hear it often tonight referred to as MI for short. And in short, it's a way to get your patients to see why we are recommending what we are, and maybe to understand where they're at, and to bring them around to our way of thinking, and to participating in their care more efficiently. So this is a course of study that people devote their lives to, and certainly anybody who attends a 1 hour lecture is not going to be amazing at it. So tonight, really, we wanted to give you a taste of what MI is about, and if you're interested, give you resources to follow up on it further. Think of it sort of like learning another language. So tonight, we're very lucky to have Dr. Alec Miller, PsyD, who is the founder and clinical director of the Behavioral Care Center of New Jersey. And she specializes not only in MI, but in CBT and DBT. She graduated cum laude from Tufts with a BA in clinical psych and English, and received her master's and doctorate from the School of Psychology in Rutgers. She did her pre-doctoral internship at St. Luke's Roosevelt and her doctoral hours at Montefiore. And she's conducted research regarding social emotional program planning and implementing in schools. And in collaboration with Dr. Alec Miller, she contributed to the adaptation of DBT for elementary school children. She's our expert in MI, and we're really excited to have her tonight. And with no further ado, Dr. Miller, please take the floor.
Thank you, Dr. Lashley. That was a really nice overview of MI. We might not need the hour. We'll see. We'll see how it goes. So thank you for the introduction. I'm excited to be here and to talk to everybody tonight. I'm going to share my screen and put up the slides so that you don't just have to hear me, but have something to look at as well. So we are going to be talking about motivational interviewing, or MI, and it truly is just a taste. Hopefully will whet your appetite and you'll be interested in learning some more about it. That was a really great introduction, so I don't have to introduce myself. Just in terms of my experience with pediatrics specifically, I grew up with a parent who is a pediatrician, and then spent a lot of my time working before private practice in community settings and in hospitals, hand in hand with our primary care providers, with pediatricians and RNs, working to help the kids. So I am looking forward and excited to see a group of pediatricians who are interested in the mental health side of things. And what I really love about motivational interviewing is how it really spans both worlds and is a nice bridge between the two. The one thing I will say that Dr. Lashley did not mention when he talked about me is that I tend to speak really quickly. I've been given that feedback my entire life. If I'm speaking too quickly, don't worry about being rude. Just interrupt me and let me know, and I will slow down. I'll likely forget and may need another reminder to slow down again. But feel free to hop in and let me know if I am going too quickly. Also, I'm really excited and passionate about the material. So I have a lot of material for us to cover. And you may notice I skip through some of it a little more quickly than I do others. So our goals for today is really just to give you an overview of MI. So we're going to talk about a few different pieces of motivational interviewing, the spirit, the 4 processes, and we're going to talk a little bit about the core techniques. It really, truly is just a taste. If you are interested in learning more, there are so many great ways to learn more about motivational interviewing. There are tons of books out there. There are trainings with some really wonderful trainers. There are people who are open to supervising who will help. And at the end of the day, it is just practice. While it's true that after 1 hour, you're not going to walk away feeling expert in MI, the thing that will get you there is just a willingness to jump in and try it out, and to see what feels right to you and how it integrates into your practice. There's a famous psychologist, Paul Gilbert, who founded a type of therapy called compassion-focused therapy. And he was in a training once, and somebody asked him a question, and he put it back to the attendee, and they said, well, you're the expert. How can I answer? And he said, the only thing that makes me an expert is that I've failed more often than you have, right? That really what hones skills is a willingness to just jump in and to try and see how things go. So what we're going to start with is, why are we talking about MI? How is this even helpful? So MI is helpful in a few different areas. We know that motivational interviewing has been shown to increase the likelihood of patients following through on protocols that we've set. So it increases adherence. It also can increase the quality of care and can lead to improved outcomes. What's interesting is when they rate patient satisfaction, that for clinicians, for physicians who are using MI, tend to get higher ratings of satisfaction by their patients. And really interestingly, the research has also shown that it decreases burnout. So they found this in both physicians and also in medical students, that both groups who were actively engaged in using motivational interviewing had lower rates of burnout than their peers who were not actively engaged. So it seems to be that there are multiple benefits for this, some for us, some for our patients. And so it's a helpful intervention. So what are we talking about here, right? What is motivational interviewing? There's a new basic, so the basic book for MI, the initial one, there's a million books now, but Bill Miller, Steve Rolnick, the creators of MI, have the core original textbook. They've gone through a few editions. They're actually now on their 4th edition that I think you can now pre-order on Amazon. Some people have been able to get advanced copies. Some people have a little bit of a wait, so it depends how lucky you get. This definition is actually from the most recent before this, right? The one right before. I like it because it's thorough. So this is how they described MI in their last book. Motivational interviewing is a collaborative, goal-oriented method of communication with particular attention to the language of change. It's designed to strengthen an individual's motivation for and movement toward a specific goal by eliciting and exploring the person's own arguments for change. That's a lot of words. The pieces to it that are most important is that MI truly is collaborative. It's not an intervention you can do to your patients. It really is something that we engage with together, and it is goal-oriented. So it is different from supportive interventions in that it's not just about providing support. There is a directionality to it. We'll talk tonight about the importance of language in MI. So much of motivational interviewing is about really listening for and eliciting types of language from our patients. And at the end of the day, our work is really about helping our patients find their reasons for making change happen, helping them find their motivation for it, helping them connect with their values and engage in behavior change. You'll see that I sometimes will go back and forth between patients and clients. It's because I often talk to mixed groups, and different people call the people they work with all different things. So I will try to stick with patients, but I might fall back into clients every so often. So this is the newest version of the book on motivational interviewing. And one of the changes that they made, it's a smaller book than the last edition. And one of the things they've really been focusing on is broadening the tent pegs. They want MI, they want people to feel comfortable engaging in MI outside of a clinical community. They want physicians to feel comfortable and coaches to feel comfortable. This is not an intervention for psychologists. So they've shortened the definition to reflect that. So the definition in the new book says that it is a particular way of talking with people about change and growth to strengthen their own motivation and commitment. So why use motivational approaches? Why engage in MI? The reality is it works. So it started off in the addiction world. I'm not going to give a lot of the history of it, but it started off in the addiction world, and there is a lot of evidence about its efficacy in the addiction world, and it has been now utilized and implemented in other areas as well. So there are a lot of positive trials with using MI with specific medical conditions. For example, There is specific research that highlights the efficacy in helping patients with cardiovascular disease make the changes they need to make to stay healthy. Not only has it been studied in sort of a traditional therapy role where you're meeting with your patient every week for 45 minutes, they have also looked at brief versions of MI. Some of them are single meeting sessions that are intertwined into a medical appointment, so it's not a separate therapy visit. And those have shown to be effective as well in a whole host of areas, things from hypertension to managing diabetes. The reality is that at that point, they're no longer researching whether it works. It has been accepted that it is an evidence-based intervention. The research now is really looking at how to optimize and how to integrate motivational interviewing into the way that you're already working. I'm not going to go through all the next slides. I just really wanted to highlight all the different areas that as research supporting the use of MI. So we have in reproductive health and managing diabetes, with substance use, with diet. There's certainly in the mental health realm. They've even done some research into decreasing kids' exposure to secondhand smoke in the home when physicians are using MI with family members. So at this point, we know that it works. And it really does focus on how we listen to our patients and how we talk to our patients. And what we know is that communication style is a significant determinant of treatment dropout, of treatment retention, adherence, and outcomes. So it's helpful to remember that, for a long time, we thought that when people were not following through on things, that it was intrapersonal, right? That there was something in them that was making them not follow through. They weren't being compliant. And what the research is really pointing to is that there's a stronger interpersonal impact than we initially thought, and that the way we communicate with our patients has a huge impact on whether or not they stay in treatment, whether they follow through on the plans we put out for them. So MI is a really lovely way to slow down and look at how we communicate with our clients. So we are going to start first with the spirit of MI. Now, motivational interviewing absolutely has lots of techniques to it, and that's often where people want to jump in. But the reality is, if you use a technique without the spirit, it's not likely to be effective. In the same way that a screwdriver is a really effective, useful tool, but it's not going to be much help with a nail. So we want to make sure we're slowing down. And if you take one thing away from today, I would sooner have you take away a piece of the spirit than one of the tools. Because no matter, so for example, one of the tools is how to use open-ended questions. Now, if you ask an open-ended question in a way that's not consistent with the spirit, you're not actually engaging in MI. But if you do embody the spirit and you're asking a closed question, you're still engaging in MI. So the tools are just ways to help you integrate it into your practice. But more important than the tools themselves is the spirit of motivational interviewing that drives the use of the tools. This has one of the small changes that has been made from the 3rd edition to the 4th edition. So Steve and Bill created acronyms. As I'm sure you all know, therapists love acronyms. And so there are a lot of acronyms in motivational interviewing. They purposefully chose the acronym PACE for the spirit because it really is the pace of your interactions with your patients. So PACE, we're going to go through each piece of the acronym in more detail as we move on. The one that has changed from the last edition is this last one. This used to be a different word here, and they've replaced it with empowerment. And we'll talk about why in a moment when we get to the spirit. So when we talk about this idea of partnership, it comes down to the fact that in MI, we really focus on shared decision-making. At the end of the day, even when we don't want to, the reality is that our patients ultimately get to decide if they're going to make change happen or if they're not. Even when we know that they're engaging in behaviors that aren't healthy for them, even if they are smoking, even if they need to lose weight, even if they need to use contraception, even if they need to go to school, right? Even if they're making decisions that are objectively not healthy decisions for them, at the end of the day, it does end up being their choice. And it's important to remind ourselves of that and to respect that while we're working with them. The same thing with parents. Parents will sometimes make decisions that we don't agree with and it's not how we would like to treat. And at the end of the day, it is up to them to decide to make some of these decisions moving forward. So this idea of partnership is that this isn't something we do to our patients. This is a joint process. We're really working together. And that while I may be the expert in my field and you are the expert in your field, at the end of the day, they are the experts in their lives. And, there's a patient I'm working with who is getting a lot of pressure to make a change in how they were managing their diabetes. And he said, it's finals right now. Even though I know I'm supposed to do this and it's what's going to be healthier for me, I cannot do it right now. I need a week. And unless there was something imminently life-threatening, everybody had to ultimately give him that week that he needed to get through before he was going to be able to do it. If his physician hadn't slowed down to ask why it was a bad time, it could have just turned into an argument. You can't wait. This is important for your health. Why would you do that? But instead, the physician slowed down and really talked to him to figure out why it wasn't the right time and could make a feasible plan for him to only a week later, so still pretty quickly, start engaging in change. So this really comes down to honoring your patient's autonomy, no matter how badly we might want them to make change happen. I do also provide dialectical behavior therapy, which is a kind of therapy that we use with kids who are self-injuring and who are suicidal. It is really hard sometimes to hold on to this and to remind myself to honor my patient's autonomy when they are engaging in really concerning behaviors, right? And my telling them what they need to do when they're not actually open to changing it isn't helping, right? It's not going to lead to behavior change. So ultimately, if my goal is to help them make change and to help them live healthier, happier, less distressed lives, I have to kind of go at the right pace for them and honor their autonomy through that process. So I had a supervisor who once said to me, in terms of this idea of honoring autonomy, you can have the best car in the world. It can go 0 to 100 in seconds. But the reality is, at the end of the day, if there's no gas in the car, it's not going to go anywhere. And I think about motivational interviewing often as that gas that the car needs. You have these great cars to offer your patients. You know how to help them make the changes they need to make to live healthier lives. But if there's no gas in that car, they're not going to ultimately make that change. So this idea of honoring autonomy comes in and really allowing our patients to make the decisions that they're ready to make with our offering our guidance as we can. We want to shy away from this idea of, I know what you need to do to get better. We can offer it. But what we know from research is that the patient's perception is more predictive of outcome than ours. I might be convinced that this is the thing that's going to help and make their life different. If they're not on board for it, that's not going to matter because their perception is more predictive than mine. We also know that relationships impact efficacy. So patients feeling comfortable with us, their preferences, their goals, feeling connected, that matters in terms of their willingness to follow through on what we're offering. So we have partnership as the first step in the spirit. The next step has to do with acceptance. So Steve Rolnick is one of the founders of motivational interviewing. He wrote this back in 2006. The way he described acceptance was that you want to look for ways of conveying this acceptance to the patient. Try not to let go of this idea. You have no desire to pass judgment on them, and you consider anything they say or do as acceptable, or as at least something that does not surprise you. Working with kids and with teenagers, they say some pretty astounding things sometimes, and making sure that we're able to sit with them and listen to them without judgment allows them to keep talking about it. That doesn't mean you have to condone everything that they're saying or doing. The problem when judgment sneaks in is that it slams the door shut. So we do want to be able to have open conversations with them and create a non-judgmental space where they can really talk about what's happening for them and how to help them make healthier decisions. And I will say that doesn't mean that you have to condone any behaviors that are concerning to you. There is a balance in there where you can be non-judgmental without condoning. So someone once, I don't know where this quote first came from, but this idea of acceptance is seeing with your heart and not with your eyes. So what does acceptance actually mean? It means recognizing the absolute worth of each patient. Teenagers in particular really struggle with finding adults who are willing to see their worth, particularly if they're kids who struggle. They get a lot of negative feedback from a lot of the adults around them. And so having a place where you can have an honest conversation without being judged or put down is immeasurably important for them. Part of acceptance is offering accurate empathy. So helping them feel heard and helping them feel understood. Also, supporting the autonomy of every patient is part of acceptance. Whether or not we agree with them, they do get to make their decisions at the end of the day. We also want to affirm their strengths, which we'll talk more about when we talk about affirmations. So we've talked about partnership, we've talked about acceptance. The next piece of the spirit has to do with compassion. There is a group started by Paul Gilbert called the Compassionate Mind Foundation, and they describe compassion as a sensitivity to suffering in self and others with a commitment to try to alleviate and prevent it. So my understanding is that the root of compassion has two pieces to it. It has passion and come, which is together, to suffer together. So compassion literally means to suffer with. So when you have compassion for somebody, you don't just pity them. You don't observe sympathetically from the outside, no poor thing, but you really can feel with them their sadness. You can feel with them what they're going through. You're suffering with them, with the added piece of our goal is to alleviate and prevent that suffering. Most people become doctors partly because that's important to them, to alleviate suffering, whether that is physical suffering, whether that is emotional suffering. We want to keep people healthy and content and happy. So compassion is one of the core components of that spirit. Not just because it feels nice or because we want to be people who make kids feel happy and good, but we also know that the more compassionate providers are, they've found that diagnoses tend to be more accurate and found earlier. And the hypothesis for that is they find that when patients are feeling the compassion from their providers, they're more willing to divulge information. When they're feeling judged, they tend to hold back what they are willing to report. And then you're trying to figure out what's going on with half the information. So the more they can feel comfortable and understood and heard, the more willing they are to be more open, which then allows you to both be quicker. Sometimes people will say, I only have so much time with a patient. I have to hit my expectations for the day, how many people I have to fit in. I don't have time for this. Sometimes spending a little more time actually ends up saving you time in the long run. And so I thought it was just an interesting bit of research to share. We also know that patients who feel that their providers are compassionate tend to be more likely to adhere to the treatment plan. So they assume that their providers only have positive intent. They trust them more. They're more willing to follow through on what their providers are suggesting. And there was a study, it's a little while back now, but of the physicians who were surveyed, 87% of them who reported an erosion in their enthusiasm for medicine attributed that to the loss of empathic care, that they felt that they didn't have the time and the ability to be compassionate in the way that they'd like. So the spirit, again, we have partnership, acceptance, compassion. You can see why these need to be, the spine of the intervention, because no matter what tools or tricks you're using, if you're not doing so in partnership with your patients, if you're not coming from a place of acceptance and compassion, it doesn't matter how sharp the tool is, it's not likely going to do the job. The last bit of the spirit has to do with empowerment. So what they say about empowerment is no matter what reasons the therapist might offer to convince the client of the need to change their behavior or how much they might want the person to do so, lasting change is more likely to occur when the client discovers their own reasons and determination to change. So again, if our patients are not empowered to make these decisions, they're not likely to make the change at all. Our wanting it for them isn't enough. Now, this used to be evocation in the spirit. Evoking is still part of the treatment. They've shifted where it is. They took it out of the spirit because they were worried that evoking sounds like something that you're doing to your patients. And they really wanted the spirit to make sure it reflected. Our job is to help shore up and help our patients feel empowered, not for us to do something to them. We're not giving them something that they're lacking. We're helping them notice what's already there, the strengths, the resources, the abilities, what's already there that they have in them. We're just helping them find their own store of all of that. And then at the end of the day, when we don't like it, that change is certainly a choice, and our patients have autonomy. People will sometimes say to me, I really want to learn motivational interviewing because I want my patients to listen to me. They don't listen to me and they need to listen to me more. So I need to learn MI to get them to listen. And the reality is MI doesn't do that. So motivational interviewing, I wish it would be a lot easier if motivation worked like this, that you could pick up your pitcher of motivation and just pour it into your patient, right? And just fill them with motivation, and then they would walk out of your office and lead healthier lives. But the truth is, it doesn't work that way. Motivational interviewing takes the perspective that we're not pouring it into our patients. Our patients are a well, and we're helping them lower the bucket to find the water that's already there. They have the strengths in there somewhere. They have the reasons for change in there. They have values. They have motivation. We're not giving it to them. We're helping them find it. And sometimes it can be buried pretty deep. So when it comes to empowerment, we want to connect the change goals to our patients' beliefs and values and concerns. Typically, people are ambivalent or stuck when they don't recognize that there's a discrepancy between where they are and where they want to be. Now, some of our patients need some help connecting that where they want to be is not where they are now. They might not care that they've missed a ton of class, but they think that they're going to college in 2 years where they're going to live on their own. We know they're not going to get there if they miss too much school, but they don't know that yet. So we have to help them understand that their goals for themselves may not be aligned with where they currently are. Some patients see where they are and see where they want to be and just feel ineffective about closing that gap. So for some of our patients, what we have to do is start to learn a little bit more about what matters to them and what their values are to help them see the chasm between where they are and where they want to be. Some of our patients see that clearly already, and what they need our help doing is figuring out how to cross that divide, how to feel confident and capable of making those changes and what those steps can look like. At the end of the day, we can give all the reasons why we think they should make change, but at the end of the day, we need to hear from our patients why they want to make that change, because people don't generally make change for someone else's reasons. And if they do, they're short-term changes. They don't turn into long-term sustainable change. So providing information is an important part of your job as a physician. So certainly, by all means, I do not mean don't provide information. You also want to make sure that you're leaving some time to first hear from your patients if they may have any reasons why they might want to make change happen. We also want to hear from them what strengths they might have already to make this change happen. They might surprise you. And sometimes, especially depending on their age, some of their strengths are friends to rely on or family members to rely on, or, a tendency to be able to stick with something once they've decided it's important to them. We want to really hear what that might be. It might be humor that helps them get through difficult moments, but we want to hear from them what their strengths are to help them make that change happen. So that was the first part that we're going to be talking about. That is the spirit of motivational interviewing. So we have partnership, acceptance, compassion, and empowerment. And certainly I'm happy to answer any questions about that at the end, but that is the backbone that's going to hold up the rest of the treatment. These next steps are the processes. These are linear processes. The spirit's not linear. You don't start with partnership and then move into acceptance. The idea is that you really want to embody all of those things in your interactions with your patients, which is different than the processes. So the processes are these linear steps. And it works like a traditional set of steps, not so much like the steps in this picture, but engaging, that bottom step is the foundation that everything else rests on. So you want to start with engaging, and it's not until our patients are engaged that you want to move into focusing. Once you focus, then you move into evoking. And once you're done evoking, then you move into planning. Now, that linear process can take a minute and a half, and that linear process can take 6 months. It depends what the targets are, it depends what you're working on, it depends on your patient's readiness to jump in and to make change happen. So when we talk in a little bit about some of the skills and the strategies, they fit underneath these areas. So for example, I know I'd mentioned open-ended questions. How you use that open-ended question. First, remember, we want that spine to be in place. The pace should be there, the spirit. So when you're asking open-ended questions, it should come from a place of partnership, acceptance, compassion, and empowerment. But the open-ended questions you're going to ask when you're engaging your patient is going to look very different than the open-ended questions you're going to ask when you're in the focusing stage, when you're in evoking, or when you're in the planning stages. So all of the skills that we're going to use can be used a little bit differently when you're in each one of these steps of the interaction. So why do we start with engaging? Why is that the first step? At the end of the day, we know that higher patient engagement actually improves outcomes. So it's going to be an important first step to have in place. They found that patients are less likely to be readmitted to the hospital within 30 days of discharge when they rated high levels of engagement. There are also fewer medical errors when patients are more engaged, partly because when they're engaged, we actually get more information from them. They're listening to us better. So it can also lead to improved diagnostics for all the same reasons. What's interesting is they found that patients who had higher levels of engagement were more likely to engage in preventive behavior. So not just that they were more responsive to what their doctors told them to do after there was a problem, but they were more likely to plan ahead to try to prevent a problem from happening. Patients who have higher rates of engagement are also more likely to follow through with what you've put together for them. They're more likely to listen to your recommendation when they're engaged in treatment. When people are recovering, people who have higher rates of engagement also tend to recover faster. So we know that mindset matters in recovery. It seems that engagement does as well, which seems pretty tied to mindset. So that first step is to make sure your patients are engaged with you. If they're not engaged with you, it doesn't matter what comes next because they're not listening to you. Now, lack of engagement in kids can sometimes look really just polite. They're yesing you, they're nodding their head when you're talking. They are outwardly appear engaged, but they're checked out and they don't know what's going on. Some of our patients are not engaged in a pretty clear way, and they let us know they're not engaged with their behaviors, with their language. The same goes for parents. I say patient, but when you're treating the kid, you're really treating the whole family. And so, especially for the little guys. So when their parents are in there, you can also have politely disengaged parents who are yesing you, but not actually following through. And you can have parents who are very direct and letting you know they don't agree. But once you have an engaged family, an engaged patient, then you can move on to focusing. So once you know you've got them connected, you have to now figure out what you want to prioritize and what you're working on. The problem, if there's not a focus, is if you're pointing in too many different directions, it's hard to be effective in any one or know where you're going. And some of our patients come in with multiple problems, and the time that you have with them in your office is already going to be pretty short. It's certainly not going to be enough time to focus on, weight loss, asthma, going to school, hygiene, all the things they may be struggling with. So thinking about what is the priority to them, what's the priority to you, how do you focus your conversation around the most important bits, knowing that you can make follow-up appointments if you need to come back and talk about some more things. Sometimes we get nervous that we're not going to get them back in the office. And so we end up just sort of like dumping everything out to make sure. I don't want them to walk out of the office until I've said everything that's important to say. But what ends up happening is they end up not hearing anything because it can be overload. So once we have them engaged, we then want to focus the conversation into a particular area. Once we're focused, now we move on to evoking. So that first step, we got them engaged. The next step, now we know what we're talking about, which is important. Otherwise, what are you trying to evoke? So when we're evoking, we want to think and be really thoughtful about what you want to evoke and what you're hoping to hear your patient talk about. Now, one thing we can sometimes evoke are disadvantages of the status quo. So you can ask your patient, what are some things, I know you're not worried about your drinking. At the same time, I hear mom and dad are a little bit worried. What are some of their worries about it? Even if they're not ready to talk about their own beliefs in the reasons why they should curb their drinking, I'll take it if they'll talk about their parents. Even if they're talking about how annoying it is, I'll take it because at least we're talking about the disadvantages of the status quo. That's true for any behavior, right? What are some things about smoking that your friends might be concerned about, whatever the behavior is we're targeting with them. That's one route to go. Another route to go is to try to evoke the advantages of change. So I know it's been really hard to focus on being more consistent with your insulin use. If you woke up tomorrow and all of a sudden it was much easier, how would your life be different? I want to hear them talk about what would be better in their life about being more consistent. Then we can come back to talking about how to get them there, but I want to get them bought into it first. And if they start talking about how life would be better when they're engaging in healthier behaviors, now I've got a better hook when we're talking about how to make that happen and how to make changes. So certainly one route is talk about advantages of change. Sometimes what we're hoping to elicit or to evoke from our patients is just an optimism about change, especially if you have patients who come in who are depressed or a little bit withdrawn. They're not, one of the barriers for them, they might see that discrepancy between where they are and where they want to be. They might not feel hopeful about their ability to cross that divide. And so then part of our job is to try to help them find some optimism in there. Even if it's a kernel, I'll take it as a starting off point. And that can look different, but one way to do that is just asking, what strengths do you have that would help you succeed? Who in your life can be a support? What's something that you have, tried and worked really hard on in the past and stuck with? What helped you do that? So these are all, if you notice, these are actually all open-ended questions, and they're all being asked with the goal of evoking something particular from the patient, whether it's why it doesn't make sense to stay status quo, why they do want to change, or potentially some optimism about making change. The last one that's in here is trying to ask questions that might evoke their intention to change. So I know that right now you're not worried about having missed 20 days of school so far. What would have to happen for that to become a worry for you? What's the line for you where you would say, oh, that's not great. Now I might have to go to summer school. Is it hitting 25 days missed? Is it 24, right? Like I would want to talk them through what would have to change for them to start thinking about some change happening. So even if I can just get some movement around their intention to change, I'll take it when I can get it. So when we are working on evoking, so these are all different questions that we're asking. You want to be really thoughtful with what your goal of the question is. Are you trying to get them to talk about the disadvantages of the status quo? Are you hoping they're going to talk about the intention to change? So you want to be thoughtful about the language you're using and what questions you're asking. At the same time, you also want to be really mindful of their language. So language really matters. And these are two different types of language that we talk about in MI. One is change talk and one is commitment language. Change talk is anything that our patients say that has to do with them wanting to make a change happen. So I know for me, something that I talk about often is that I absolutely need to get more sleep. I'm exhausted. I would definitely be less cranky if I slept more, probably be more efficient the next day if I slept more. There's 1,000 reasons why I need to get more sleep. I need to do it. I want to do it. I should do it. That's all true. Sometimes in our office, we hear change talk and we get so excited to hear change talk that we're jumping on and making a plan. Like, oh, you want to get more sleep? Great. Here's what you do. You set an alarm on your phone at this time. You shut off all electronics at this time. We're often running, making a plan. But the reality is change talk is not commitment talk. Change talk is just the first step. Commitment talk is the language that our patients use that express that not only do they want to change, which is change talk, but that they are ready, willing, and able to make that change. So it's not just, I've been saying I want to get more sleep for years now. I don't know if I've ever said, that's not true ever. Rarely have I said, tonight's the night I'm going to get into bed early and shut everything down, because I have important things to do that I have to get done. And I'm not actually prepared to make that sacrifice tonight because I want to get things done. So the difference between change talk and commitment language matters. Change talk is a start. We want to make sure we respond to change talk. We want to reinforce change talk. We want to jump in there when we can, but planning really is most effective after you've heard commitment language, not just change talk. So,
Mark, I just want to jump in for a sec. One place where we could really use that help is smoking cessation.
yes.
Like we get a lot of patients that say, I wish I could stop. And then we have other patients that say, help me stop. So we can see the difference between the commitment talk and the change talk.
Absolutely. And then you have those patients who will say to you, it's not healthy for me. I know it. They can give you all the reasons. They're well versed in why they shouldn't be doing it and why it's bad for them. And that's change talk too, right? I know I shouldn't. It's not healthy. It's bad for my lungs. My girlfriend hates it. My parents get in trouble, whatever it may be. But then they keep coming back to you and they haven't actually quit yet. And I think sometimes when we're feeling stuck and frustrated because we think, oh, we've had this conversation a million times, it's because they've been using a lot of change talk, but not quite yet commitment language. Right? So it sounds like semantics, but it does matter. So one way to kind of highlight this is one of the most important questions people will ask is, will you take this person to be your lawfully wedded spouse, to have and to hold for richer or poorer in sickness and health, as long as you both shall live? I could say I want to, which is nice to hear. I'd like someone to want to marry me. That's not what I want to hear on the actual altar. Someone could say, well, it's important for me. It's important for me to get married. It's a little bit better, but we're still not quite there yet. Maybe the worst thing I could hear is if someone's answer to that was, well, I should. I want someone to marry me because they should. That is change talk. That is definitely not commitment language. But shoulds we get so excited about in the office, right? I should quit smoking. Sounds like, yes, you should. Absolutely. Let's come up with a plan. Let's work on it. How are we going to do it? But if they're not really ready to make the commitment yet, then they're just talking about it, not really ready to do it. What I want to hear is, I do. I am ready to quit smoking. I know it's going to be hard and I'm ready to work on this. So the way that we use language matters, and how we respond to that language matters. We want to use the techniques of MI when you hear change talk. So affirmations in particular, reflections can really be used to strengthen change talk and to increase the likelihood that you'll hear commitment language. They've done this really interesting research where they have people flip back and forth from an MI approach to a directive approach, back to an MI approach, back to a directive approach. And then they rank the patient's response, the language they're using in response. And you can watch the commitment language rise and fall with how the physician or their provider is talking to them. And so how we respond when we hear change talk can impact whether we're likely to hear commitment language or whether we're likely to hear them fall back onto some sustained talk. So our responses matter. At the end of the day, both change talk and commitment language are great. I love hearing either one. Sometimes we have patients where we're hearing neither of those things. They're not interested in talking about change, and they're certainly not ready to engage in change. So what do we do in those moments? One thing that changed in the third iteration of MI, so the one right before this newest one, is they took the word resistant out of the book. The reason they did that is they said they found that resistant has become an adjective, right? Oh, this kid has talked to me about not smoking for the last 2 years. It's so resistant to actually doing anything about it. Or those parents have said that they are going to make a change in the diet that they're giving their kid and they just won't do it, right? Resistant became this way of describing people who are unwilling. And they found that didn't help people move towards change. So what they did is said, instead of saying resistant, let's try to figure out the function of language. Why are people not making change? They broke it up into these two categories. One is sustained talk, And those are patients who are not interested in change. All my friends drank. I'm the one who got caught. It's really not a big deal. There is no indication in there at all that that person is interested in making that change, which is different from discord. Discord doesn't have to do with whether or not the patient is interested in change, but whether there's a problem with the relationship. So then we might hear something like, you just don't get how stressful it is to be 15. That doesn't mean I'm not willing to make change. It means I don't think you understand me enough or you understand my situation enough. So even if I was going to make change, I'm not going to do it right here, right now with you because you don't get it. So we want to hear what the function is. It's different in both of those moments. One is I don't want to make change, and the other is there's something that we have to fix in this interaction, or I need to help connect you with someone else who feels like a better fit where you're willing to have these conversations in a way that they feel open to. So I'm aware of the time. I'm going to speak quickly and get us through this. So this next piece has to do with, all right, so you're listening to language, you're listening to sustained talk and discord and change talk and commitment language, but now what do you do with it? These are the key skills of motivational interviewing. They're called the ORs. They're the open questions, affirmations, reflections, and summaries. Remember, the pace is the spirit. So while you're writing your ORs through your conversation, the pace is always going to be behind you. So open-ended questions, why do we use them? Because the reality is closed questions really limit the information you'll receive, especially from kids and teenagers. Now, sometimes you are going to want a factual answer, and then you use a closed question. How many times did you smoke this week? How many cigarettes did you smoke? That's a closed question if you're looking for a concrete answer. If you want more information, you might have to ask a more open question. So you can ask open questions with the goal of eliciting the negatives of smoking, with eliciting the positives of making change. All the things we talked about with evoking really come into play here, but it depends on the purpose of your question. Closed questions aren't bad if what you're looking for is specific information. So, for example, I can say, did you cut yourself this week? If what I'm looking for is a yes or a no because I'm noting it in the chart or I'm keeping track somewhere, then I'm looking for a concrete answer, and then that closed question is fine. But if what I'm actually trying to figure out is how they coped with stress this week, then that is what I'm going to ask. If I'm worried about their depression, I might start with, tell me about what you did when you were sad this week. If I want a larger question about self-injury, I can't tell you how many kids are referred to me because they're cutting and they come to me and I find out that they're also burning themselves and scratching themselves and hurting themselves in a host of other ways. But when they're asked about cutting, they answer about cutting and they neglect to fill in the people they're talking to about the rest. So I might say, what did you do this week when you had the urge to hurt yourself? Or if I know the person's actively engaging in self-injury, I might say, tell me how you hurt yourself this week. Because I'm looking then for more information. So I'll ask an open question. Did you cut yourself this week? Some kids will respond and give you tons of information, and some kids will just respond with a yes or a no. So you want to think about what it is you're looking for and then ask open or closed questions accordingly. Affirmations. So affirmations and the ORs are reflections of your patient's strengths, their values, their goals. Why do we affirm? It increases our patient's self-awareness of their strengths. It promotes self-efficacy and empowerment. What's interesting is when someone uses change talk, if you provide an affirmation following change talk, you have an increased likelihood of hearing first more change talk and sometimes even some commitment language after. So if you're wanting to hear your patients use more change talk or even strengthen it into commitment language, it's a great time to use an affirmation. It really consolidates commitment to change, reinforces change talk, and it can acknowledge struggles. Now, the way we use affirmations in MI, we try to take ourselves out of it. The idea is you're holding up a mirror to your patient and you're reflecting back the strengths that you see. So instead of you're saying, I'm proud of you, you might frame it as you worked really hard to make this happen, or you must be so proud of yourself, so that it pulls you out of it and really focuses on them. I have a bunch of examples of how you can frame it here. Your health is important to you. It takes courage to face these things. This is hard work you're doing. There's a lot of ways you can affirm. For the sake of time, I'm not going to have you guys practice, but I always have people practice giving affirmations, not just for people who are easy to affirm like Dorothy, but also for the Wicked Witch, because sometimes our patients and their families, they're not always Dorothy's. Sometimes people who come into us are also Wicked Witch. So the ors, the open-ended reflection, the affirmations, the reflections are all the key components when you talk about the skills of MI. The reflective listening, that reflections part, why do we engage in it? It lets your patients know that you understand them and that you're not judging them. You can use reflections to gently challenge them when they are stuck. You can also use reflections to shift conversations when it's moving in an unhelpful way into a more healthy and useful direction. You can use reflections to just check in and see if you're hearing them correctly. You can also use reflections just to communicate that you're listening. There are all different kinds of reflections. This is just a list of them, but when you do a longer training, we go through these different types of reflections and how you can use them differently, how you can use them to help your patients explore and shift away from unhealthy conversations. You can talk about how to use them just to reflect back that you hear them. Similarly, there are several kinds of summaries. Miller and Rolnick are the founders. I just love their quote about summaries. It's like collecting flowers one at a time and then giving them to the person in a little bouquet. Their patient might give you 1 or 2 reasons for change in your 10-15 minutes with them. If you can combine those 2 or 3 together, it can feel more powerful. So these are the 3 different types of summaries. And again, in longer trainings, we go through these different types of summaries and how you can use them differently. So that quote was about collecting summaries. There's something called linking summaries that can help you reflect back on previous conversations you've had. And transitional summaries are a way of using summaries to shift the conversation into a different direction. So we have gotten through most of the taste of MI. And if you're going to take the leap and try it, you should also be reimbursed for it. There are counseling codes that you can use. If you're meeting with your patients and the time has been met, there are different codes depending how long you're meeting with them for, and they are reimbursable codes. You're doing this because you care about your patients, and it's okay to care about your patients and get paid for doing the work that you're doing. So make sure that you're coding appropriately so that you can be reimbursed for it. I think I'm going to do, instead of talking about how you want to integrate it, I think I'm going to pause here because I know that people were saving questions for the end. So I'm going to pause us here and leave our last few minutes for questions, if that sounds good to everybody.
Wow, that was comprehensive and a lot. Everything that you said is so important for us and rings true. If anybody has any questions that they want to put in the Q&A, go ahead. Or if you are feeling like speaking, just unmute yourself and go ahead and ask. Erica, I think that one of the books that I read that I felt made an impact on me was Getting Past No, if you're aware of that book.
Mm-hmm.
And it's a lot like MI techniques. It's just a little different. And I think that when we meet abject resistance from a patient, it's so important not to push back in the other direction. It's a good moment to pause and understand where they're coming from. So how do you think we should approach that when we get real pushback from patients about vaccines, for example, or treatment plans?
Yeah, it's really counterintuitive, especially when you're coming in with medical knowledge that's going to help keep people healthy, and they are not listening. And not only are they not listening, but they're pushing back. And sometimes they're pushing back in ways that are frustrating because it is based on misinformation that they are convinced is accurate information. And so the urge is to push back in that moment. And unfortunately, the pushing back tends to push people further away. Whenever somebody is ambivalent or unsure, even if they're going back and forth, like whether or not to vaccinate, some people will go back and forth, and it's hard not to just lean right on, of course you need to vaccinate. If they're truly ambivalent, the problem when someone's ambivalent, what we know from social psychology research, is that whatever side you're likely to lean on, they're likely to then lean the opposite way. So an innocuous example, I remember when my husband was debating going back to soccer. Great if he does, great if he doesn't, right? Like it was an easy moment for me to not take a stand. So I said, that's a great idea. You really love playing. Well, I don't really have time, and the kids and work. And I was like, okay, if now's not the right time, then now's not I know, but it would keep me healthier, right? Whatever side I agreed with, he would make sure I knew all the reasons why the other side was also accurate. And it's how human nature works. Now, that was easy for me because that's low stakes. Soccer, no soccer, I don't really care as long as he's happy. When it comes to something like vaccinating a child, that is much harder to be able to manage that balance. We tend to just lean so heavily on one side. And ultimately, what we might do is convince the person to go the opposite way. So you want to be really careful in that dance. You want to do a lot of reflecting, a lot of open-ended questions. And even if they leave your office not ready to make a healthy choice that day, you want to make sure that the door is open and your hand is extended for them to come back, because they can storm out and never come back, or they can leave with your feeling disappointed, knowing that you've made a follow-up for them to come back in and continue discussing it. Now, there are some rules, some practices I know have rules about if you don't believe in vaccination, we don't treat you here. Some offices are open to that. I know there's different rules in different places, so that's within the confines of what the practices feel comfortable with allowing you to do.
Can you please tell us the name of that book that you say is like the gold standard for MI? And Margaret, who's working in the background, will put it in the chat.
Yes. So the book is just called Motivational Interviewing. It's not a very creative name. It's by Bill Miller and Steve Rolnick. I'm going to actually, let's see. I have a picture of it here. So this is it right here. The 4th edition just came out, Motivational Interviewing, Helping People Change and Grow, by Bill and Steve. Bill Miller was the person who first thought up MI, and Steve came along and helped him expand it into what it is now.
And if some of us are interested in attending a course on MI, is there a real good one that you might recommend for us?
There is. So motivation, what's neat about the MI field is they've not just done research about MI, they've done research in how we train MI to make us more effective trainers. So there's an organization called the Motivational Interviewing Network for Trainers, or MINT for short. And they generally keep a calendar. So you can train in MI whether or not you're a member of MINT. If you've become a member of MINT, it means you've been trained by Bill, by Steve, and by the people who teach you how to train. So if you're looking to be trained by someone who's gone through that process, they have a website that gives you trainings internationally. So all time zones, all times of day, virtual, in person. That's a good place to go.
And is it something that takes hours and hours and days, or is there a shorter course?
Depends what you're looking to get out of it. If you want to walk away feeling like you are an MI expert, you can jump in and do this. What they generally suggest are 2 to 3 full day training. And then in addition, that by itself isn't sufficient. You want to have a few follow-ups over the course of a year, every few months, that you check in about half an hour, an hour, talk about what's working, talk about what's gotten in the way. So that if you want the fully adherent way of getting trained up in MI, that's the recommendation. I can tell you one of the hospital systems kind of close to me had me come in and do 6 trainings that were each an hour. They asked for specific, we talked about these specific goals. So for example, they wanted to know what to do with clients who were stuck and how to manage that discord and that sustained talk. And so we did a whole hour just on that bit. So I don't know that they walked away feeling like they had the comprehensive MI knowledge, but they walked away with pieces of it that they felt were important to integrate into their practice. So you can find all kinds of trainings. Some are specific like that, some are broader. Steve Cole is a physician who's a member of MINT, who spent a lot of time developing an MI protocol that's brief, that's meant for primary care visits. And so he also will provide training specifically around his model for that brief intervention. And he's a good presenter.
Yeah. Mm-hmm. So I think that everybody is really interested in what's going on. We don't have any questions at the moment. I haven't told you we were going to do this. I don't know how you feel about it. How do you feel about a little role play with me for a moment?
Sure.
So you're the physician and I'm the patient, and I'd like to, let's say, start my you're, as the physician, want to start me on an SSRI medication to help me with my mood, but I'm really worried about starting SSRIs, and I have all these concerns, and I I'm not for it, and I'm really against it.
Mhm. Yeah, so I
So
would really actually love to hear, Mark, about what your concerns are. So I think making the choice to go on medication is a really personal choice and a really difficult choice to weigh out all the pieces. So help me understand what your concerns are.
well, I just know it's going to make me into a zombie, and I'm going to be a different person, and I'm going to be addicted to it, and I just don't want to be one of those people that take medication. I think that I should just be able to tough it out.
I hear a bunch of different concerns. Is it okay if we go through them one at a time so I understand them better? Okay. So the first concern that I heard is that it's gonna make you a zombie, which I hear from people quite a bit. That's a pretty common concern I hear. Is it that you've had friends who have had that experience, or is it more what you imagine being on an SSRI is going to be like?
Um, I saw some TV programs where they showed people on Prozac, and they had like this faraway expression, and I don't want to be like that.
Yeah, that makes total sense. When I'm a million years old, but when I was younger, I watched One Flew Over the Cuckoo's Nest, and people were like hanging around, drooling, and unable to move on their medications. And I remember a lot of people I knew were really scared because that's what they thought being on medication would be like. I think that unfortunately, it's so frustrating as a therapist. It drives me crazy that that media and TV shows show this really inaccurate picture that looks terrifying. Of course, if that's what you're seeing, that's what you would be scared of. I don't want you to be a zombie. I actually think you're a pretty amazing person as you are. And I don't want to take that away. I don't want your spark to go anywhere. If anything, we're talking about how to help get your spark back. So I do want you to feel 100% assured that we would never put you on something that's going to turn you into a zombie. And if you do decide, which again, it's totally up to you, if you do decide this is something you want to try, if there's any point in time where you feel like you're zombieing out, you let me know right away, because it is absolutely either not the right medicine or not the right dose for you. Because our goal for sure is not to turn you into this kind of muted walking dead. That would be a terrible way to go through your day.
So time out. I noticed a whole bunch of things you just did. So first of all, you echoed my concern, reflected. You
Mhm.
you you said back to me what my concern was, and you validated my concern. So you heard me, you reflected upon me, and then you validated me. And that was wonderful. So that's something that is so important because it really sets the stage for me to listen.
Right. Well, because if you're not feeling heard, it doesn't matter what I'm going to tell you. If you're not feeling heard, I'm just going to be another adult telling you what you're supposed to think.
Right. I mean, the wrong way to do that would be, that's not going to happen. Don't worry. Trust me. I'm your doc, and you're going to be fine.
Right.
So instead, what you did was you heard my concern, you reflected it back to me, and then you partnered with me sort of there for a moment. You said, I'm here working with you, and I've got you back type of thing. So I thought that was very powerful.
Yeah, I think you also what I remember when I was first learning how to do therapy and I would watch tapes of these gurus, right? I watched the person who founded Stomach Family Therapy and I thought he's amazing, I'm going to be him. And then I would go into session and it would bomb, because the reality is I'm not an 80-year-old guy who has all this, right? He brought this gravitas with him that I don't have. I was fresh to the field, I was very young. It was, and I learned that part of what I think makes people effective is I think hopefully you could feel in there that it's also genuine. You have to be yourself. I tend to bring in humor because I just think things can get so intense and heavy, particularly when you're talking about mental health, that if you can lighten the moment in any way, if you can be teenagers, self-effacement, that's their second language, right? If you can be sarcastic and self-effacing, it's half the battle and you've already won them. But I think that humor for me is important to bring in, but you want it to feel authentic to you. So some people don't bring in humor. They bring in a lot of warmth and compassion, or whatever it is that you bring in, you want to make sure you're doing it as you.
I love that. What about someone who's overtly hostile? Someone who comes in and is, I'm not giving my kid any vaccine, so don't even bring it up, or someone said, a lot of times, well, to backtrack for a second, Allied, our group right now, we're trying to bring up our rates of HPV vaccination. And we're all talking about best practices, and we've had several meetings where we discuss with each other, what do you do, and why are your rates higher than mine, and what is it that you're doing? And we're trying to, bring everyone up on the best practices on how to get people to vaccinate. So one technique that I use is when someone says to me that they don't want to have the vaccine, I say, I see you've declined the vaccine. Will you please tell me your thoughts, or would you like to hear my thoughts about it?
Yeah.
And sometimes a patient says to me, no, I don't want to hear what you have to say. And, nothing you say is going to change my mind. So don't even waste your breath. And sometimes it's very off-putting and hurtful. You're paying me the big bucks to give me information.
And I'm trying to prevent
you don't even
cancer.
want to hear.
Right. And
Right.
like, what more noble, you're trying to prevent cancer. At the end of the day, who would disagree with that? It can be hard. I think there's two pieces to what you did that I think are really useful. In MI, when we talk about giving advice, it's not that you're not allowed to give advice, it's that you always ask first. And what you did is you asked, do you want to hear mine? Now, people will say to me, what if they say no? And my response is always, if they say no, they weren't going to listen to you anyway. If you just want to give them the advice that you're supposed to give, then go ahead and give it either way. But if you're trying to create a space where they're going to be more likely to listen to you, then you ask permission and you respect it if they say no. And when they realize you're someone who's going to respect their no's, it makes them more open when they come back to you the next time or 2 or 3 times later. So I think asking permission is important. And I think there is nothing more helpful and there's no better antidote for judgment than curiosity, right? Like the other thing you asked came from a place of curiosity. I see that you declined it. I'd like to understand that decision better. Can you help me understand it? You didn't say like, what is wrong with you? Right? Why would you say that?
Thinking that is.
Yes, I think the beauty of working with parents and teenagers especially is noticing what you're thinking and keeping it in the back of your head and then coming up with a skillful way to frame what you want to say.
And sometimes what I say when somebody says, I don't want to hear what you have to say, and believe me, it happens more than you think. There are some things that I know about the vaccine you may not know, and if you want to hear these facts and bits of information I have, just ask me in the future, and we'll talk about it.
Yeah. Yeah. Or if you just don't want to hear me drone on, I have a handout I'm happy to give you. You're welcome to crumple it. You're welcome to say no. You're welcome to write your grocery list on the back. You can do with it what you want. I have information if you'd like it. I respect that you're telling me you don't want to hear me talk about it. If that ever changes, I'm happy to talk about it because I may have information that feels new or different.
Yeah, it's a tough one. It's so emotionally charged, and the COVID vaccine was another one, very emotionally charged.
Yeah.
And you had to be so careful with your language. People get it's a match point sometimes when people you say something. I said to someone, well, I just heard from Dr. Fauci this morning, and that's the last thing I had to say. Don't talk to me about that guy, and I'm like, oh, what did I say? And so I learned, by error, what to say and what not to say.
I don't know too many physicians who expected medicine to be politicized. I think that has been a really shocking shift over the last few years. There have been always, times where it was difficult to work with people in different opinions, but I don't know that anybody expected a medical conversation to be politically charged. And I think that has made it a lot harder. It also, I am a fan of the internet. It's allowing us all to meet this way tonight. There are huge benefits, The downside is there is a lot of information out there, and we haven't taught people how to check sources or how to look for data. So you have information coming in, and you have people who are pulled to information that confirms beliefs they've already had. And so they're coming in thinking that they're armed with information and facts and data, and they're actually just armed with nonsense that they've read. And you know that coming in, and you're coming in armed with science and facts and knowledge, and they may not be open to it. And it's very hard in those conversations because they are providing what they believe are facts, even though they're not. I remember someone telling me how the reason they weren't getting the COVID vaccine was because they didn't want the chip getting installed in them that would allow them to be tracked. And they were 100% serious and absolutely believed that that's what was happening with the COVID vaccine.
Well, my chip is functioning just fine. Thank you.
I'm not going anywhere that
Um,
exciting. If someone wants to see where I'm going, I mean, it's to work into my kid's school.
If any attendees are there, you see we're having a free-flowing conversation. If you have a clinical vignette that you want to share or a roadblock you had with a patient, please unmute yourself and feel free to speak, and we'll address it.
And
So
you can meet after today too. So if people have follow-up questions or things that they're thinking about or questions about resources, I'm happy to have, and anybody's welcome to reach out to me.
in the best way, Erica?
Email for sure. So I can put my email in the chat.
Great.
We'll put it in the follow-up email that's sent out by our marketing team as well, and we'll put the book recommendation too.
Great.
I also wrote in the chat, everybody, that just a placeholder, our next MHC meeting will be November 8th at 7 p.m. It's going to be Dr. Gabrielle Carlson from Stony Brook, and she's going to talk about emotional dysregulation and outbursts in children. Mostly it's aggression and how to treat and manage aggression in children. So please mark your calendar and join us for that one. Another reminder is that we have applied for and hope to get CME credits for tonight's meeting, as well as MHC credits for the board. So you'll be getting a follow-up email to help you sign up for those things. All right. Well, that was amazing. Great talk. I now know how much I need to learn. Because it's such a huge topic.
I think if anything, it's such a helpful reminder anytime I hear anybody talk about MI to slow down, because you get kind of wrapped up in your day and there's so many moving parts in your jobs and things you need to do. And there are high stakes. None of you have a job where the stakes are low, right? You're all working in situations where the stakes are high. It's really hard to slow down and be patient when the stakes are high.
That's so true. And all the pressures we have to see patients, sometimes just take a moment, at least pick one topic and work on that. I would say the biggest problems we have are motivation for obesity, vaccination, and getting people to take medications of certain kinds. I say that's the biggest problems we have.
Yeah, I think that, again, curiosity ends up being more useful than expected. I remember when I was working in the Bronx, there was one of the big focuses was working on childhood obesity and targeting that. And there were these resources that came in through a grant, and we had nutritionists come into the school and teach parents how to cook healthy meals with their kids, all of these amazing interventions, and they didn't make any difference. And we couldn't figure out why. And we're talking to the parents, and the parents are saying, I can't do this. This isn't helpful. And everyone assumed they just didn't want to. And when we slowed down and got more curious, what we learned is that, the local grocery store was a bodega, and the stuff that the nutritionist had brought in from Whole Foods that they were using to do the demonstrations were certainly healthy foods and not accessible in the particular area where we were. And what I really appreciate is the hospital that I worked for realized that part of the problem was accessibility, and they worked with some grants to fund green carts that could be brought into the neighborhood where, if a bag of chips costs less than vegetables that are going to go bad quickly and you are financially strapped, you're going to do what you need to get through. So they figured out that the way to solve the problem wasn't just to teach about nutrition. We had to make healthy choices accessible and realistic. And if they hadn't brought curiosity to those conversations, we wouldn't have been able to make that change happen, to make it more likely that these patients could make healthier choices.
So check in with our patients, ask them what the roadblocks are, and ask them what the resistances are, and if our advice makes sense to them, if they can implement it or not.
Right. If it's realistic in their lives, and what would have to change to make it realistic. A kid who I worked with was referred to me. She was in 3rd grade and she was so obese that she couldn't sit on the floor with her classmates. She had to sit in a chair because she couldn't get back up when she was on the floor. And I realized one of the barriers in our work together, her parents were both so obese that they were housebound. They couldn't fit out of their apartment door. And so her rubric, her expectation for what healthy looked like was so far off. Because her norm was such an extreme version of what healthy looks like, that her expectation of healthy wasn't what her parents were doing, but it also wasn't what the rest of us would think of as being healthy either. And that was a barrier we had to really, right, her understanding of it, her understanding of what's typical was not in a healthy place.
Yeah. All right. Well, it looks like we don't have any questions, and that was great talk. Thank you so much. I guess we'll end it here. Any other questions from anyone else? Okay. Well, Dr. Miller, thank you so much for alerting us to this topic and letting us know just a little bit of MI and all that we have to learn and how much it can help us as physicians. I want to truly thank you for joining us tonight.
Thank you for bringing me into this. I appreciate it.
Okay, with that, everybody, I wish you a good night. Thank you for joining our MHC, and see you next time.